This picture before. Is Dr. Groninger in the room? Okay. Not yet.
Should we sit here and wait?
No, sit here.
Just start.
Is that all right?
It's fine.
Let's be the face. I think we should get started because we're... We start at 4:45. Hi, everyone. We're going to start in about just a minute. Before we get started, this is supposed to be an interactive session. And if I understand it correctly, that the way the interaction works is that you go to the Chest Events application. Does everyone have that on their phone for the meeting? So if you go to Chest Events and you find the session, if you go to Chest Events, you get this menu of options, and there's an option called Polling. And if you go to Polling, you should see a list of different sessions. So then you should be able to scroll down to this session, which is 10639. And it says, please wait for polling to begin if you were to click on it. And I'm going to hope it's going to work when we kick it off. And we'll kick off in just 1 second. But there will be some interactive questions in everyone's talk, I think. Peter, do you have questions in your, do you have audience response questions as yours? And you do too? Okay. Okay. And one more call for Dr. Hunter Groninger. In the room yet? No? Okay. It is 4:45, so we'll go ahead and get started. I'm Anil Vachani, and I'm a pulmonologist at the University of Pennsylvania. This session is entitled Complications During Lung Cancer Treatment, Diagnosis, should be Diagnostic and Management Considerations. This is divided up into 4 different lectures, an update on systemic therapy, which I'll do, immunotherapy complications, which will be done by Peter Mazzone, symptom management strategies and palliative care by Dr. Groninger. I'm hoping he'll be here at some point during the hour, and short and long-term complications of radiation therapy. So we'll kick it off. I think. Oh, and there are the directions. I didn't know we would see those. So this is the polling app within the Chest Meetings app. And here we go. Okay. So as a part of this session, we thought it would be helpful perhaps for me to review systemic therapy in general for lung cancer. This is primarily going to be a run-through of the various advances that have occurred using targeted and immunotherapy approaches to the management of essentially stage 4 disease. I'm not a medical oncologist, but I'm going to do my best. So bear with me, and certainly if there are questions, let me know. So I'm going to do 2 ARS questions to start. We're going to then review these same 2 questions at the end of the talk, and I'm hoping the whole thing will go off all right. So the first question is a 60-year-old woman who's diagnosed with a stage 4 non-small cell lung cancer, adenocarcinoma. At the time of diagnosis, the lung cancer has metastasized to the liver with 4 small lesions. She has a performance status of 1. Biomarker testing shows no targetable mutations, and her PD-L1 level is 0, and her tumor mutational burden is less than 10. What is the appropriate therapy for her to start with? And I think I advanced the slide. Oh, so it like does it in real time. Look at that. Is there staff in the room? When do I know polling is over? Oh, I can just advance? Oh. Okay. Everyone was done with the first question. We'll go to second question too. So, I'm sorry, let's step back. So we see what the responses were here. Two-thirds of you picked carbopemetrexed, and a third of you approximately picked pembro, carbo, and pem, a very small number picking nivo and ipi. And we'll come back to these same questions at the end and go over the answers. Second question. A 64-year-old woman with adenocarcinoma, metastatic to the liver. Biopsy shows that she has an EGFR deletion and 80% PD-L1. Erlotinib was initiated and she had a good partial response initially. About a year later, a CT scan shows growth of her liver lesions, so progression of her disease. She has a biopsy of the metastatic lesions indicating the tumor, that the progressing metastatic lesion did not have a T790M mutation and did not otherwise indicate a known mechanism of progression. So no other mutations were identified on whatever broad-based panel was done at that time. So at this time, with progression of stage 4 disease after erlotinib with no new mutation, what class of therapy is the most appropriate for this patient to receive? Chemo, immunotherapy, or targeted therapy? Okay, pretty broad split. Most of you saying immunotherapy, 20% saying chemo, and 20% saying targeted therapy. And we'll come back to this at the end. So we'll dive right in because I'm probably already way behind schedule. There's certainly been an evolution in the treatment paradigm for non-small cell lung cancer in the last 20 years or so. I still remember when I was a fellow in training, I was taught this New England Journal paper where there were 4 platinum doublets tried, and they were all essentially the same. And the rule was you can use any of them. You sort of use the regimen you want because it's based on side effects and what's most tolerated by that patient. And so we've come a long way in terms of developing various molecularly targeted therapies and various immune-targeted therapies. And I'm going to just show a snippet of some data from these trials just to get you a sense for what's being done currently. These are the targeted therapies currently available in non-small cell lung cancer and the gene mutation that they relate to. And I won't go through this in terms of any great detail, but we know that primarily we're looking at these 7 or 8 mutations as being the key drivers that we're looking for during mutational testing, though your own institutional testing may be testing for many, many more genes. These are the ones that really have actionable targets where drugs exist and that can be used in patients today. While I won't show any single trial from all these various targeted agent trials that have been done, this is sort of one summary trial where the experience was shown across the use of targeted agents across a broad number of patients, showing that anyone who has a mutation who gets a targeted agent does better than someone who has a mutation and does not get a targeted agent or has no driver at all. This was published in 2014 and summarizes really the vast experience across many, many different trials and many, many different agents. The experience here can be also pretty profound, right? So this is an example of a patient who had an ALK mutation, ALK translocation, and was treated with crizotinib. And you can see that this effect that we see is so much better than what we used to see with traditional doublet chemotherapy, at least for a short while. There have been sort of 2 recent trials probably worth knowing about. There are newer generation ALK inhibitors that have been shown to be better than the initial ALK inhibitor that came on the market, crizotinib, and I won't go through this in great detail, but you can sort of see the effect here with newer generation inhibitors being better than first generation crizotinib. Similarly, there are newer generation EGFR inhibitors compared to the first generation inhibitor, so osimertinib, which is a inhibitor of both of many EGFR mutations, including the T790 resistance mutation, appears to work better in the first-line setting compared to standard EGFR TKI therapy. So this is sort of moving into replacing the standard of erlotinib, which has been present for many years. In the interest of time, I think I'll skip through that one and jump to the immune-targeted therapies. Immune-targeted therapies, as many of you know, really focus in on this interaction between PD-1 and PD-L1. PD-1 is expressed on T cells. The concomitant molecule or cell surface marker is PD-L1, which is expressed on tumor cells. This is essentially a brake on the immune system so that when either of these proteins are blocked, it takes the brake off the immune system and you get T-cell activation and a tumor killing effect, relatively simplified. Similarly, CTLA-4 is also a brake on the immune system, which is expressed on T cells. And when that brake is taken off with a drug such as ipilimumab, it also leads to increased tumor killing and tumor activation, T-cell activation and tumor killing, used primarily in melanoma, but also some emerging evidence in lung cancer, which we'll show very briefly. So these are the checkpoint inhibitors that are currently available on the market, IPI, which is the CTLA-4 inhibitor, nivolumab and pembrolizumab, which are PD-1 inhibitors, and several additional ones in development, and durvalumab and atezolizumab, which are the PD-L1 inhibitors, which are currently available for non-small cell lung cancer. Let me just review the data very briefly. So some of the original trials that came out were in the second-line setting where nivolumab and pembrolizumab were compared to standard second and third-line agents, and you can see that they had improved progression-free survival compared to standard chemotherapy. At least in the case of pembrolizumab, it was initially believed that this effect was driven by expression of PD-L1. So while this is a little bit hard to see here, this is PD-L1 expression of over 50%. And these patients did better with pembrolizumab when compared to patients that had lower levels of expression. Subsequent trials have compared pembrolizumab to platinum-based chemotherapy in the upfront setting in patients who don't have a targeted mutation and that had PD-L1 expression. So in that setting, pembro did better than standard chemotherapy. Again, no targeted mutation and PD-L1 positive in that setting. And then subsequently, we've gone on to add pembrolizumab to platinum-based chemotherapy. And as you can see here in the original phase 2 trial of pembrolizumab with the platinum doublet, it was improved progression-free survival. And then I'll show this, the phase 3 trial in just a moment. This effect appeared to be somewhat PD-L1 driven, where PD-L1 biomarker, again, being greater than 50% expression, patients did a little bit better than those with pembrolizumab than those that had lower levels of expression. The subsequent, and I will skip through this, the subsequent phase 3 trial of upfront pembrolizumab plus chemotherapy in non-squamous metastatic non-small cell lung cancer was published quite recently. Again, showing here the effect of the pembro combination versus without pembro for both progression-free survival and overall survival is improved considerably with the addition of pembrolizumab. This effect appears to be somewhat independent of PD-L1 expression, so that if you look at PD-L1 expression by less than 1%, 1 to 49 and 50, the effect is still statistically significant across all three strata. Although, as you do see here, that the absolute objective response rate does appear to be better when PD-L1 is higher, the difference in terms of the effect of using pembro versus placebo is the benefit is maintained across all levels of PD-L1 expression. Lastly, we'll very briefly touch upon this idea of tumor mutational burden, or the burden of the total number of somatic mutations present in an individual's tumor. As you can see here, the tumor mutational burden at a somatic level appears to be highest in tumors such as lung cancer and melanoma, tumors where, not coincidentally, these immunotherapy agents appear to be working best. There is some evidence that suggests that the more the tumor mutational burden predicts response to therapy. So patients here who have a high level of burden doing better than those that had a low level of tumor mutational burden. And one recent trial showing, at least in lung cancer, that the combination of nivolumab and ipilimumab did better than traditional standard chemotherapy, particularly amongst patients that had a high tumor mutational burden. So this is an evolving story, and we'll see where this goes as we move forward. All right, that was it. Brief, right? Let's go back to our questions, though. So this is question number 1. Oh, the answer is already shown here, which is very disappointing. This was supposed to have been programmed to show that the answer would be answer number 4, which is that in a patient who has a newly diagnosed stage 4 lung cancer, who has no targetable mutations, even with a PD-L1 level of 0, and ignoring the tumor mutational burden for a moment because that is not used clinically to make any decisions, based on the recent evidence that I just showed from Dr. Gandhi et al. In the New England Journal, pembrolizumab plus carbopemetrexed would be the appropriate regimen to choose here for this patient. And we're essentially just moving away completely from using either a platinum doublet alone, and at least in most settings being able to move away from using pembro alone. Now remember, if you have a targetable mutation present, like EGFR ALK, you would still get the targetable agent, the targeted agent for that mutation as the initial therapy. But in settings where there are no mutations identified, in most patients we'll be seeing the use of a triplet now with immunotherapy. Now, I don't want to give away the answer to question number 2, which I suspect will happen if I change the slide. So I'm going to go back and show that question again going this way. So here's question 2. This is the patient, again, who had advanced stage 4 lung cancer, adenocarcinoma, had an EGFR mutation, got erlotinib, then progressed, and testing at the time of progression showed no new mutations, and specifically no T790M mutation, which was the resistance mutation that osimertinib is good for. So in this case, if people would be willing to answer again, would you use chemotherapy, immunotherapy, or targeted therapy? And I probably didn't give the answer for this question in my talk very clearly, but we'll talk through it after you answer it one more time. And I guess I have to hit enter. And I don't know if this will update or not if you guys change your answers now. All right, so the answer here is chemotherapy, and that's because, as I pointed out, that there was no new mutations identified where a targeted agent could be used in this setting. And there is relatively good evidence that in the setting of having a driver mutation, immunotherapy, for whatever reason, doesn't work as well. So the standard second-line approach is still in this setting to use a platinum doublet for treatment. Okay, that was it. Thank you for your attention. This sets the stage now as you understand sort of the rationale for why we use immunotherapy agents much more frequently than we just did a couple years ago, to think about the various complications that these agents have and potentially how to deal with those complications. So I invite Peter Mazzone from the Cleveland Clinic to do that review with us. Thank you, Peter.
Thanks very much for inviting me, and thanks to all of you for coming out late in the day. This is the same instructions for answering the polling questions as you've already seen. So I was asked to talk about immunotherapy complications, their diagnosis and management today. I'm going to very, very briefly touch on the rationale for their use and why immune-related adverse events may occur. I'll show you a couple of examples that you might not see in clinic. I have non-lung complications. Then kind of a frequently asked question, general considerations about immune-related adverse events. We'll talk more about pneumonitis, what we might see in our practice, and finish with ASCO guideline summary of pneumonitis. So the first question, a little bit easier, I think, than Anil's questions, I hope. Which of the following is correct? A, activation of the immune checkpoint PD-1 is the only way a tumor avoids the host immune system. Or B, immune checkpoint inhibitors have been approved only in lung cancer. C, immune checkpoint inhibitors are approved in the first and second line for some patients with lung cancer. Or D, we are able to accurately predict who will have an immune-related adverse event. So we'll have your answers. Fabulous. It's good to feel good about yourselves late in the day, for sure. So the first is the rationale for the use of immune-type therapies. For a cancer cell to grow, it has to be able to evade the body's immune response to it. And it can do that in multiple ways. It can do that by excluding activated T cells. Cancer-related fibroblasts may set up an extracellular matrix, release chemokines that make it very difficult for activated T cells to penetrate into the tumor. Second is the tumor can find ways to lead to ineffective cytotoxicity of activated T cells, here showing decreased expression of the first apoptosis signal on a cancer cell. The third, the one that we're talking mostly about today, is immune checkpoint activation. So these immune checkpoints are body's natural defenses against our immune system overwhelming our body. And so we have to have this system in place to turn down the immune system, and the tumors use that to their advantage. They express PD-L1, leading an activated T cell to either become a regulatory T cell or just to die off. And then finally, antigen presentation in tumor-draining lymph nodes by dendritic cells may be ineffective. In this particular case, when ineffective antigen presentation occurs, it may lead to immune tolerance in that lymph node. So once the tumor cells start to travel there, the immune system doesn't attack it. All of these areas are active areas of investigation for immune therapies. The one we're talking about today is the one that's reached the farthest, and that's immune checkpoint inhibition. And as Anil showed you, the other rationale is they work. So lots of studies now, first and second line, different positive groups and combinations, all now shown to improve outcomes in lung cancer patients. And you'll see similar tables in other cancers, melanoma, kidney cancer, lymphoma, Merkel cell tumors. So these agents and their complications, when the patients reach your clinic, they may not all be coming to you after a lung cancer diagnosis. So why might immune-related adverse events occur with immune checkpoint inhibitors? Well, unfortunately, this system is not unique to the tumor, but it's important to controlling inflammation throughout the body. And so by blocking that system, you might increase T cell activity against antigens present in the tumor and in healthy tissues. You might increase levels of pre-existing autoantibodies. The checkpoints are also felt to modulate the humoral immune system. Activating the immune system may lead to increased inflammatory cytokines. Immune checkpoint inhibitors may bind to immune checkpoints on normal tissues and enhance complement-mediated inflammation. So because this is nonspecific release of the body's immune inflammatory system, you may see an impact on organs throughout the body. And in fact, immune-related adverse events have been reported in virtually every organ and tissue in the body. A couple of examples. This is a lady in her 50s with melanoma who was treated with pembrolizumab. And after a few cycles of her therapy, she started to develop blurring of her vision, left eye more than right, and some sensitivity to light. Her evaluation showed that her visual acuity was down, and there was mild inflammation noted in the anterior chamber on her exam. Pictures of the back of the eye showed cystoid macular edema, and she was diagnosed with immune-related uveitis. She went on to have intravitreal injection of a corticosteroid, and the immunotherapy stopped. And post-treatment, her images look much improved. This particular gentleman had metastatic bladder cancer treated with atezolizumab, and he developed this rash, pruritic papular pustular rash, during his therapy. The rash went on to be biopsied. The biopsy showed both superficial and deep perivascular and interstitial lymphoplasmacytic infiltrate, and no other reasons for this to happen. So this was felt to be a complication of his immunotherapy, which was held and was treated with topical and systemic steroids with benefit. This was another patient with melanoma treated with pembrolizumab again. This patient developed microscopic hematuria, saw a rise in their creatinine, also developed headaches. Had a kidney biopsy, it showed a crescentic immune-mediated glomerulonephritis, and other testing didn't show any other reason for that to be occurring. And blood work suggested a hypophysitis as well, with an elevated prolactin, decreased testosterone, and ACTH. The drug was stopped, corticosteroids were started, and some of these values started to improve. So these events can occur in any organ at all. Let me just take you through a few frequently asked questions, general considerations, and then we'll focus on pneumonitis, what we might see mostly in our clinics. First is, when might you expect an immune-related adverse event to occur? It's said to usually occur within the first few weeks to months after treatment, but it can present any time, and the symptoms or signs may wax and wane over time. Second, why do these events occur in some patients but not others? Active investigation. We really don't know why at this point in time. Some have speculated there are genetic factors or microbiologic composition of someone's GI flora that impact someone's likelihood of developing one of these immune-related adverse events. Are these events associated with the efficacy of immune checkpoint blockade? So the thought here might be, hey, there's evidence now that blockade's activating the patient's immune system, so maybe the outcomes of treating that tumor are also going to be better. In general, the consensus is you really don't need to have evidence in other organs to have a response in the tumor. However, for some of the events that are directly related to the antigen in the tumor, there may be a better benefit. For example, if you develop vitiligo when treating a melanoma, that patient may have more success with their treatment. How do you treat these? At this point in time, without a whole lot of evidence, it's just sort of common sense. You stop the drug that's leading to the side effect if the side effect is severe enough, and you consider treating with corticosteroids based on the severity. If those fail, then more aggressive immune suppression. With that in mind, if you're treating with immune suppression, does that reduce the anti-tumor efficacy of checkpoint blockade? And there are retrospective looks at this. In general, the feeling is they don't impact the outcome, that the outcome is just as good even if you have to treat with steroids. However, recently there was a study reported that suggested if your patient started treatment already receiving 10 milligrams of prednisone or more for an unrelated condition, that the efficacy of treatment was lower. Is it safe to restart therapy? Maybe that therapy was working. It's the only thing you had for that patient after a serious adverse event. Again, no hard evidence here, but generally there's been found to be a relatively low rate of recurrent immune-related adverse events. New ones can be triggered. So if the initial one was mild in nature, you can restart therapy. However, if it was a life-threatening toxicity, then absolutely you cannot. Is it safe to treat patients with autoimmune disease? Again, a paucity of evidence. This group was excluded from all of the clinical trials that showed benefit. So this is one retrospective multi-institutional review, 56 patients, lung cancer, and an autoimmune disease. Almost 1 in 5 had active symptoms or were receiving immunotherapy, like steroids at the time that treatment was initiated. Over half either developed a flare of their autoimmune disease or an immune-related adverse event. Most of those were mild, and only about 1 in 7 had to stop treatment or be started on steroids. That leads us to question 2, now shifting over to pneumonitis. Which of the following statements about pneumonitis resulting from immune checkpoint inhibitor use is correct? A, pulmonary toxicity is reported in 20 to 30% of patients receiving therapy. B, patients with lung cancer who receive an immune checkpoint inhibitor are more likely to develop pulmonary toxicity than those being treated for other cancers. C, a unique imaging pattern and pathologic findings help to discriminate immune checkpoint inhibitor toxicity from other causes. Or D, all patients with pulmonary toxicity from immune checkpoint inhibitors require treatment with systemic corticosteroid. You'll have your answers now. A little bit more mixed here, and we'll try to answer these as we go on. So the epidemiology of pneumonitis, I see various numbers out there. The ones reported in most reviews suggest anywhere from 2 to 4% of patients will have pulmonary toxicity, though some studies have reported higher numbers. Men, former current smokers, patients who are treatment naive have a higher risk, and there's a higher risk of pneumonitis in patients with lung cancer than in other cancers that are treated, the lowest being in melanoma. The median time to onset's a couple of months, though again it can occur at any point during treatment. Combination with radiation therapy, double immune checkpoint inhibitor therapy, or one of the targeted therapies has been suggested to increase the rate of pulmonary toxicity. How might these patients present? Well, unfortunately, nonspecific, just like all of the other conditions we tend to treat. Cough, dyspnea, hypoxia, chest discomfort, fevers. It's important to keep other potential complications of the therapy that patients are receiving or the tumor themselves in mind when assessing somebody for these symptoms that could be related to pneumonitis from the immune checkpoint inhibitor. What do you do to diagnose this condition? Chest radiographs aren't great. CT scans can really show any pattern at all. Ground glass changes, consolidations, nodules, so on and so forth. PFTs may be restrictive with reduced diffusing capacity. Again, nothing specific here. A decision on whether to sample an abnormal imaging finding may need to be made. And what you're doing there is mainly ruling out other things that might look like that. Infection, pseudoprogression, or tumor growth. These are just some examples of patterns of imaging findings that have been related to pneumonitis. Reticular changes and nodular changes, consolidation, ground glass changes, pleural effusions, and nothing is excused. There's even been some reports of sarcoid-like reactions with lymph nodes growing, FDG avid, and granulomas compatible with sarcoid on biopsies connected to immune-related adverse events. How do you manage patients with pneumonitis? If they have no clinical features, you might monitor them through their treatment. If it's clinically apparent, withholding the immune checkpoint inhibitor and considering start of corticosteroids depending on the severity is what's currently recommended. Again, these are common sense rather than true evidence-driven recommendations. For severe toxicity, grade 3 or 4, you will permanently discontinue the immune checkpoint inhibitor. This is a couple of examples of pneumonitis. This person presented with a right middle lobe infiltrate. Unclear if that was an infection or other cause, so a bronchoscopy was performed. The bronchoscopy did not identify any tumor, did not identify any infection. Inflammatory infiltrate with lymphocytes and eosinophils was noted. Patient had their immune therapy stopped, started on corticosteroids, no antibiotics, and that infiltrate disappeared. Another patient, this one a melanoma patient, developed ground glass changes, was treated with steroids, and as the steroids were being weaned, developed some adenopathy in the chest. Went on to have bronchoscopy performed, and that adenopathy showed granulomas, no tumor, compatible with a sarcoid-like reaction, leading to enhancement of the immune suppression for that patient. So to summarize the area that we'll see most often, the pneumonitis area, I just wanted to share with you the guidance from a recent ASCO guideline. And the guideline writers admitted that this is not truly evidence-based like some other guidelines, only because there isn't the evidence there to support strong recommendations. But it is a common problem that we all need guidance for. So I'd encourage you to look at this, well-written document. How do they define pneumonitis? Focal or diffuse inflammation of the lung parenchyma, and they highlight that there's no symptomatic, pathologic, or radiographic feature that's pathognomonic for pneumonitis. Say the diagnostic workup should include imaging, measuring oxygen levels, and considering an infectious workup. And then they give a nice table grading the degree of pneumonitis and suggesting a management strategy for each grade. So for grade 1, your patient would be asymptomatic, and the imaging finding would be confined to one lobe of the lung or less than a quarter of the lung parenchyma. You can continue to treat unless there's radiographic evidence of pneumonitis progression. At that point, you'd have to stop treatment, follow closely, and if progression continues, then treat them as if they were a graded level 2. Grade 2, symptomatic, involves more than one lobe, or 25 to 50% of the lung parenchyma. The recommendation is to hold therapy until they've returned to a grade 1 or lower, to treat with prednisone. Dose recommendations and tapering recommendations, again, are best estimates, not evidence-driven, and you can individualize that to your patient. Consider bronchoscopy and empiric antibiotics based on your patient scenario. Again, not to diagnose the pneumonitis, but to rule out other potential causes. Monitor very closely. Grade 3, severe symptoms, hospitalization, all lobes of the lung, more than 50%, limiting self-care, oxygen needed. And grade 4 is life-threatening toxicity. Permanently discontinue the therapy, empiric antibiotics and prednisone. If no improvement quickly, then consider other immunosuppressives. And again, these aren't evidence-driven. If your patient can tolerate it, bronchoscopy with BAL can be considered. So overall, I hope I've been able to give you a little bit of a rationale for why we're using immune therapies, and particularly immune checkpoint inhibitors, why we can expect these events to be occurring, giving you some examples of other organs, and focused a bit on pneumonitis, what we might see a whole lot of in our practice going forward. Thanks very much for your attention.
Thanks, Peter. Dr. Groninger in the audience? Going once, going twice. Since our third speaker isn't here, we actually do have some time for questions. So if you don't mind, could I have you come up to the microphone up there?
Since these pulmonary complications can occur, it seems like every person who starts this medicine should actually get a baseline CT so you know what, if it's new or old, if these pneumonitis can occur. Has that ever been considered?
I'm sorry, I had a little trouble hearing the question.
With
I think that mic may not be on, but
Whether or not to get a baseline CT.
a baseline CT prior to. I think that it just so happens that almost all patients have a baseline CT, but prior to starting whatever systemic agent or regimen they're going to be on, and so we feel like there is that ability to go back and compare any findings that you might see during immunotherapy to their baseline CT. I think that if for some reason you felt like that CT has been quite some time prior to them starting systemic therapy, I think it's a reasonable conversation to have with their medical oncologist on getting a new baseline prior to immunotherapy institution.
So my question is regarding the side effects with pneumonitis. It reminds me of, as older physicians, we had to deal with bleomycin toxicity, which was a higher incidence. And when we dealt with that, a lot of times people treated before treatments for with bleomycin, they did diffusion capacities or spirometries before going to the next course of therapy. Is that going to be what we're going to recommend for therapies in this line of therapy, immunotherapies for patients, to avoid the incidence of pneumonitis?
I don't know of any evidence to do so. Peter, I don't know if you want to comment.
I think it's certainly part of what you're following when you're assessing somebody with new findings on their imaging and deciding whether or not they're improving enough to consider restarting things. I don't know that there'll be a too low function test level to guide someone about whether to use these therapies when they may be.
Yeah, for instance, with Leo, I think the recommendation was if they drop 25% in the capacity or diffusion, you hold the therapy until they recover before you give them further therapy. But they're not talking about that now in terms of that?
So, guidelines, they are suggesting that you do monitor periodically, not just imaging, but pulmonary function tests. And you like to see those improving before you would, take your therapy away, or you would restart an immune checkpoint inhibitor. But an absolute number like 20, 25, I haven't seen that anywhere.
And in terms of steroid therapy, is it 4 to 6 months, like in Bleo we used to do, or we still do, and a titration after like a couple of months? Is there any recommendations?
It's based it on the grade that they said 4 to 6 weeks with dropping therapy by 5 to 10 milligrams every week. And again, that's general guidance for you. And if your patient's been very slow to recover and respond, you certainly may extend that out much longer. I think we've all in our clinics seen quite a variety of responses to treatment.
Thanks.
Okay, great. This gives us an opportunity to move on to complications of radiation therapy, and I'm delighted to have Russell Hales from Johns Hopkins University with us. He's a terrific radiation oncologist and, frankly, a terrific friend of Chess because he's been here just about every year for the last few, giving us updates on radiation therapy. So I'm delighted that Russ is here again this year.
Thanks so much. And thanks to each of you. You know, at the radiation oncology conferences, we start at 11 and we finish at 2. It's Sunday night, almost 6 o'clock. What's going on, guys? So, for what it's worth, we really don't start at 11, and we really don't, you know, it's those California conferences where you go east to west coast, and the first one's at 7 in the morning, and you're really feeling it. Or if it's going the other way, it's even worse. Well, I'm happy to be here today to talk a little about radiotherapy and about complications. I will focus only on pulmonary complications, although it should be said during therapy that esophagitis and issues related to that more vex our patients than anything that goes on with the lung. But in the setting of brevity, we'll just stick to pulmonary complications. I am on a health economics advisory board for AstraZeneca. I'm going to be focusing on 3 things. Number 1, I'm going to teach a few things about what's going on with radiation technique and how that's a double-edged sword. It's both good and bad. We'll talk about that in detail. We'll then talk about pneumonitis and when it requires intervention. And then we'll finish by talking about SABR or SBRT and how we think about pulmonary findings. All right, so let's talk about radiation technique. So we've now moved from a conventional to an intensity modulated approach. And I think in all of your practices, community or academic, that you're going to be seeing therapies that you see on the right. What happens in conventional therapy is that a standard port is drawn. The beam goes directly through the patient. You get effective targeting of the tumor, you get homogeneous dose throughout, and so you see a lot of toxicity in high-dose regions. So you can see this patient's more likely to develop a cardiac toxicity because this open aperture beam going straight through the patient is going to give homogeneous dose. Compare that with intensity modulated radiation, where now you're giving thousands of little beamlets in multiple directions that wrap around the patient. And that has the effect of giving a very focused conformal dose of radiation to a small area. So this is a good thing, but I want to suggest that it's not uniformly good, and I'll describe why. So here's a patient that we've treated. Let me describe exactly how we do this. If the beam was coming out of the screen, it would be shaped by these multi-leaf collimators, or MLCs. They're about 7 inches thick. They're 5 millimeters in terms of one to the next. There's 150 of them. They're all on their own motors, and they move in real time. So here's how it works. The beam is coming out at the patient, going out into you guys. And here we're going to turn on the beam, and here's what we have. As the beam is on, in real time, you can see doses coming out of the machine. Watch what happens to the aperture of the beam. As the dose is going out, the aperture of the beam will constantly be changing because those motors are constantly moving and changing into different shapes. What does that functionally allow? What it allows is for one static beam to actually become multiple beamlets of varying intensity. Here we'll see the film paper, and while it doesn't project perfectly, you can see there's darker areas receiving full dose interposed with lighter areas receiving little dose. If you can do that in multiple directions, you get a very conformal treatment that wraps around the patient. But here is the Achilles heel of that process. In reality, I showed you a plan that has 7 or 8 different beams. Now what we do is we arc the beam around, and as the beam is arcing around the patient, that multi-leaf collimator is dancing in a very coordinated fashion to deliver this plan that's prescribed. Well, what is the downside of arcing a beam around the patient? Well, on the one hand, you get this beautifully conformal plan. These are dose clouds. The red is the target, and these are high-intensity dose clouds. But then you also get this. These are low-intensity dose clouds, and you can see how those low-intensity dose clouds lead to what's called a low-dose bath of radiotherapy. So what happens with more contemporary radiation is not that we magically avoid treating the lung, but simply we diversify our risk, that we decrease the intensity of the radiation and prescribe it to more areas. And that is a that is a problem if a radiation oncologist isn't being very disciplined and constrained in thinking about how to minimize that low-dose spath, or at least to use it in a very strategic fashion. So in radiation oncology, we communicate with something called dose volume histograms, DVHs. Perhaps you've heard about these in your tumor board. I'm going to briefly describe them. They're pretty simple. They're just a mathematical model that shows us as a function of multiple structures, and each of these spaghettis are different structures. This is the targets, and each of these are different structures. One may be the spinal cord, one may be the right lung, one the left lung. This is the normalized volume of that structure and the dose of radiation. So here's how it works. If this is the dose volume histogram for the total lung, what this would tell us is that at this mark, that 7% of the volume of the total lung is getting 20 units or 20 gray of radiation or more. And so we can use multiple points along this line to predict radiation toxicity. And so in radiation circles, we talk about things like V20s, V10s, VO5s. We talk about mean lung doses because those are all points that have been shown in literature to predict for outcome. Qualitatively, here's what you need to understand, that this would be a safer plan than, say, this, where we have a V20, or the volume of the total lung getting 20 gray or more being 13% of the lung. So intuitively, the DVH is going to be a surrogate marker for a risk of pulmonary toxicity. Here's what can happen. Remember, this is the line that I showed you if a plan is carefully being constrained. This is the actual plan that was delivered to the patient using IMRT. And can you see how it inflects in the low-dose region and deflects in the high-dose region? That's happening because IMRT is spreading that around. So the radiation oncologist, that was me, early on in my career was not disciplined at doing that, delivered a lower or a higher low-dose bath to the patient. Because the lungs are sensitive to radiation, it probably would have been better to have used older techniques than newer ones as we're using now. So we have to take great care to account for a low-dose bath. So IMRT I don't want to make it sound like it's a bad technology because clearly it's a great technology. In fact, in a recent randomized study that looked at the role of dose escalation of radiation, subgroup analysis looked at patients receiving older techniques, 3D conformal, versus IMRT, and showed a decreased rate of grade 3 or greater pneumonitis from 8% to 3.5%. And that when we looked at outcomes of pneumonitis, that radiation technique was an independent factor predictive for that. So it clearly gives the radiation oncologist a lot of degrees of freedom, but those degrees of freedom have to be used with great discipline. All right, so let's talk for a minute now about radiation pneumonitis. I am grateful that our colleagues in medical oncology are joining us in this quest to try to figure out how to treat this, how to diagnose it, because it is clearly a clinical diagnosis. But it should be noted that the pathways of and treatment for radiation pneumonitis can be similar and yet different than immune-related. Immune-related pneumonitis is often something we throw at steroids very quickly, but I'm going to suggest today that we should perhaps think differently about that. So let's go to one question. The early administration of anti-inflammatory agents, such as steroids in radiation pneumonitis, can decrease the risk of radiation fibrosis. So if we get those steroids on board quickly, maybe we'll have a decreased risk of radiation fibrosis. For those of you who like to look at the screen and see how everybody else is voting to determine your own answer, I'm waiting.
Russ, I think you press once now, and they will, okay, now they'll get to vote.
Okay.
So it opens it up on the...
So don't look at the screen. Yeah, so perhaps my preamble incentivized you on that one. Indeed. So we'll talk about this one. I would say that the correct answer on this one is false, that the early administration of steroids has not been shown to decrease the risk of radiation fibrosis, but it can make you feel pretty good because your patient is feeling better until they come in 2 months later with PCP. Okay, so radiation pneumonitis usually arises after radiation 1 to 3 months, but it can arise anywhere within the first year. It's temporary, but can be prolonged symptomatic change in breathing. Pneumonitis and fibrosis have distinctive molecular pathways, which is probably part of the reason why the early administration of steroids does not seem to change the risk of fibrosis. Treatment of pneumonitis with steroids hasn't been shown to modulate this risk. And the clinical diagnosis is a triad usually of dyspnea, dry cough, and fever, confirmed by radiographic findings, and the incidence is 5 to 15%. Okay, so how do we treat pneumonitis? Well, here's a few guidelines or suggestions. Number one, please involve your radiation oncologist. We caused this toxicity, we should own it, right? So we're gonna work with you guys, but there's nothing that is like fingernails to the chalkboard, quite like somebody who's been started on steroids that I treated, that they come to see me and fall, and I'm like, really, you're on steroids? Sometimes those steroids are not necessary. Why is the radiation oncologist helpful? Because they can predict the likelihood. I can tell you the patients I think that are probably going to develop it and those that won't. So if I have a patient who has a very low risk plan and has clinical symptoms suggestive of pneumonitis, we may want to have a long, hard thought about whether or not to treat it with steroids, or think, oh, they just had chemo and were neutropenic. Maybe we should be doing a bronch to look for an infection. So go ahead and get a CT, because the CT will often correlate with the radiographic findings. This woman with right-sided breast cancer has radiographic findings that nicely associate with her radiation plan. Well, radiation pneumonitis can affect any part of the lung. Practically speaking, it usually affects those areas that were treated with radiotherapy. And so when it doesn't fit appropriately, consider a bronchoscopy. Interstitial lung disease keeps me up at night. We will treat these patients, but we attempt not to if we can, unless there is an indication where the only chance for cure is to treat them. These patients have a very high risk of pneumonitis. And so any time somebody has ILD, we tend to have a very low bar for starting steroids. Steroids can be diagnostic and therapeutic. If you have a patient with suspected radiation pneumonitis who's not responding to steroids, you should probably be getting a bronch, because there's probably another process going on than that. And remember, not all pneumonitis requires steroids. In fact, the only time that I personally start steroids for patients is if they're dyspneic at rest or if they're hypoxic. A lot of my patients come in with a dry cough 3 months after radiation, and I can treat that cough with steroids and it will go away until, again, they develop PCP 2 months later because you've had them on high-dose steroids. Or I can give them Tessalon pearls or some other supportive medication for a process that is bound to go away on its own. So again, this patient now, a few months later, had resolution of what we see there. Certainly, in patients that are very uncomfortable or are struggling with their breathing, it's not the steroids are a bad thing. They should just be used with caution. Okay, I want to move on to the last topic, which is the idea of radiation changes after SABR or stereoablative body radiotherapy, also known as SBRT. So what is that? That's these high doses of radiation that your radiation oncologist, who used to bring their patients in 5 days a week for 7 weeks, is now bringing them in for 2 or 3 days to give an ablative form of radiation. Mass light consolidation, the process that you can see in this image, occurs in what % of patients after SABR, and can be a diagnostic dilemma because it can be misinterpreted as tumor progression. A, 5%, B, 15%, C, 55%, or D, 80%. You all are great test takers, but you're wrong. This is great. This is exactly why we should have sessions like these, so we can teach things. All right, here we go. So mass light consolidation occurs in up to 55% of patients. In fact, it depends on the study you look at. It's probably anywhere between 30 and 50% of patients who develop this, and it can be misinterpreted for tumor progression. So here are 3 patients that I treated. You can see their pretreatment tumors in these images right here, here, and here, treated all of these with SBRT. This is their 3-month post-treatment scan, where you can see nice ablation of the tumor, some ground glass changes around in this patient. You can see a nice reduction, not a lot going on around here, around the lung, and you can see near resolution without a lot of radiation change. So I don't know that we would call any of these patients having mast light consolidation. But this patient clearly did, and we commonly see this. And what's surprising is that these patients come in with, frankly, scary-looking scans, but they're often completely asymptomatic. They have very few changes. And the key is to look at the coronal slices, because the radiation comes in such a coplanar way that it looks ugly. Can I use that word? It looks ugly on axial images for about 5 slices, but then you turn the coronal on, and it's a very pancake distributed, very flat process. So 30 to 50% of patients, it's a diagnostic dilemma, because if you use strict RECIST criteria, you may be led to the conclusion it's progressive disease. So in this study of 80 patients who had mast light consolidation, or had SABR, a little over half had mast light consolidation by RECIST. 35 of 44 would be considered to have had a local failure. When they did PETs, only 10 of the 44, which was still a high number, that was 20%. And when they biopsied, only about 10% of patients had this. This is something that requires education of radiologists, of pulmonologists, and of radiation oncologists. When we started our program at Hopkins, the first 20 patients I treated, I thought I was failing. They were all having this occur, and I thought, boy, all of my patients are recurring. And after a lot of unnecessary biopsies, PETs, and even a few wedge resections, we found out that clearly this process was a normal radiation change that we should do less is more and hold the fort. So what are predictors of tumor progression? So in all of these patients, tumors progressed, and in all of these patients, there was no tumor progression. 3 subsequent rises in volume after treatment are associated with tumor progression, whereas in those who didn't progress, tended not to see 3 subsequent rises. But it's worth noting that even in the 6 to 12 month range, there can still be variability where the scan is looking great until it's not. You're best off just to continue to watch that carefully. The other thing that can predict for the likelihood of tumor recurrence is increasing volume after a year and a SUV max in relation to pre-treatment imaging that's 1.2 higher than pre. Now, it should be noted that one exception to this is in ground glass or semi-solid nodules that have very low metabolic activities. Those patients are often going to have much higher metabolic activities as a consequence of the radiation. A recent study has suggested an SUV of under 5 would be considered consistent with mast light consolidation. Clearly, these are challenging numbers. You're going to be better off just to watch these patients. So in this patient who had this tumor and these radiation changes that continued to grow, a PET showed activity, and when it was in the bucket, there was tumor. And in this patient that had metabolic activity prior to therapy, increasing CT-based changes showed no PET activity. So PET can be helpful, but not pathognomonic. So in this patient that I showed you, we waited another 3 months, and you can see partial resolution. And if I was to show you additional images that go out beyond this, this continues to resolve and eventually almost entirely go away. Okay, so we've talked about how radiation and contemporary radiation techniques gives more degrees of freedom for plan objectives to the radiation oncologist, but with those objectives come responsibility. And we need to be aware of the low-dose radiation bath. Not all radiation pneumonitis requires steroids, and mast light consolidation is a common finding after SBRT. Please involve your radiation oncologist in treating radiation pneumonitis. Thank you very much.
All right, thank you, everyone. I know it's late, so those of you who would like to leave can. We have a couple minutes if anyone has any questions, and you're certainly welcome to come up to Dr. Hales and ask questions up here if you'd like. Thank you again for coming, and we apologize that one of the presentations was missing today.
He just actually, he says my flight was delayed a couple of hours just then.
Oh, all right.
Hi.
That was great.
Oh,
Great
thanks.
talk. So I missed your point on following that, so I get the point, just kind of wade.
Yeah.
CTs, but if you're concerned, that might be.
So that's a good question. I think in the stepwise approach of when do you start with, when do you go to just observation versus PET, here's what I do. I do a 3-month scan, and I do another 3-month after that. If I'm seeing progression, I keep them on 3-month intervals. If everything was looking okay, I go to 6 months at that point. I wait for 3 subsequent rises before I activate the PET scan at that point. And you have to be very cautious with how to interpret those SUV values if you're treating a ground glass or a semi-solid nodule, because they usually have SUVs of 1.2, 1.5, 2.0. They're very low to begin with. So I think what I'm getting at is a lot of what I had to do was convince our radiologists these weren't tumor progression. And I still, what ends up happening is when you get the PET, if it's tumor progression, there'll be a focal area within the mass-like change, they'll be hot. And if it's diffusely SUVs of 2 or 3, that's radiation change. And so I think it can be helpful because of its, basically, when you get this very focal appearance, it's more likely to be tumor.
Last question, not really pertinent to this talk. So what's your protocol for following these patients with CTs? Interval, how long?
Yeah, great. So we're trying to homogenize this at Hopkins because it's the Wild West and everybody does their own thing. So it depends on the stage and the type of treatment. So if we're talking about stage 1 patients treated with SBRT, I scan 3, 6, 12, 18, 24, and then annually from there.
Got it. Thanks.
Yeah, absolutely.
Hey, Russ, I'm sorry to interrupt you.
Yes.
I have to run to another meeting.
Okay,
It's a pleasure to
absolutely.
see you.
Yeah,
Safe
absolutely. Good to
travels if I
see
don't
you. Thanks.
The old literature for radiation pneumonitis
Yes.
is sometimes based on Guy, or whatever the GYR something.
Okay. I'm not sure.
It's the dose that they would give.
Oh, the grade, yeah.
Yeah, the grade. So
Yeah.
they would say if it's more than like 5,000 or 6,000, or what was the number
Yeah.
to be associated with?
Yeah, you know, it's not simply a dose of radiation because it depends on how that dose is distributed, right?
Yes, so that's what I'm wondering. If they give the old way, would you call your radiation oncologist and say, okay,
I'm not familiar with what you mean. The dose of radiation matters far less than how it's being distributed. So we look at things called the V20, the VO5, V10, and those are going to be the things that, if you want to know what predicts for radiation toxicity, it's going to be a V20 of greater than 35%, a VO5 of greater than 55, a mean lung dose of greater than 20. But this is why you need to involve your radiation oncologist, because those are things that they're going to have access to.
okay, so it's okay. So you'll look at the V. Okay. All right.
Yeah.
Okay.
So those are what portion of the lung is receiving X dose versus.
So they should be able to tell you what the probability of if this is pneumonitis.
Absolutely.
Okay. Okay.
There's even prediction models where you can plug and chug and get a value.
Okay. All right. Thanks.
Yeah, absolutely. Hi.
So, hi. So regarding the SBRT,
Yeah.
think there are the new guidelines recently came
Yes.
up. And what's now the maximum size of the nodule that you put
Well,
in
that's
SBRT?
an evolving.
Okay.
You know, what I would say is that right now a good rule of thumb is 5 centimeters. But I like to tell people that the size may matter less than where it's at. If it's kissing the aorta or if it's kissing the pericardium and it's 10 millimeters, it's going to be very, very hard to treat. If it's 6 centimeters and in the periphery of the lung, you can nail it.
Okay.
And so location may matter as much as anything else. Yeah.
And the second question is
Mhm.
that what's your experience about managing radiation-induced poop as compared to
Yeah.
pneumonitis?
You know, I think that these are all sticky topics. So you could probably teach me on this because I put them in the same bucket. In fact, I don't. To me, it's how hard we went to look for the diagnosis. I think if you took a lot of our pneumonitis patients and did bronchs, you'd get a lot of boop.
Yeah, it's the conventional the teaching is that the radiation-induced poop is basically outside the port of radiation, and the radiation pneumonitis is usually at the site where the radiation is given.
Yeah.
And we used to have a lot of these cases, as when I did my fellowship from Sloan.
Yeah.
We used to manage them pretty much the same way, but the only thing we saw that we had to give longer therapy for boop cases sometimes.
That's interesting. You know, I'll say that our rate of grade 2 or greater pneumonitis at Hopkins is 12%, but 8 of that 12%, and please don't take this the wrong way, is because of well-intentioned but misinformed pulmonologists that started patients on steroids that I think probably didn't really require them, but we still had to call it. Well, and I think it's because you see a patient, I can help, I can do something for that. But I'll say, changes in the lung outside of the radiation field, in my experience, is pretty uncommon.
It's not very common.
What about with IMRT though? You mentioned that the lung gets a bath.
It does.
So does that change?
It can, and this is why, so if you're not careful, they'll just send every beam in every direction, and it'll be beautifully conformal and wrap around, but you'll get this horrible low-dose bath, and the patient will get pneumonitis. So if you look at my...
Outside of the field?
Yes.
Right, okay.
So if you look at my radiation plans, I'm strategic. If it's going to be trimodality, chemo, rads, and surgery, and I know it's going to be a right upper lobectomy, I'll shove all the dose through the right upper lobe, because it's coming out and it'll be in the bucket. And I stay off of the left lung. We just published a paper showing if you do that, you get far fewer. So you have to be very strategic about how you think about. I mean, that's the beauty of IMRT is you have so many degrees of freedom, but it's like getting in the cockpit of an airplane. You better know how each of those buttons work, right? Please.
Hi. Sorry. Thank you so much. I was going to ask, have you had any experience, like, with Durva being now in stage 3 with the risk of pneumonitis?
Yeah, so it's probably additive, meaning that if Durva's risk is 10% and radiation's risk is 10 to 15, we're seeing 20 to 30% risks with Durva.
Right.
I think the more challenging question is in patients who have grade 1 pneumonitis. And the data didn't talk about this, but I think grade 1 is probably 30, 40%. I mean, it's really, how many patients come in 3 months after and have a little dry cough and a little dyspnea, like everybody?
Right.
But they don't even want intervention, it's just pretty mild. So the question is, just starting those patients on Durva, because we know starting Durva within 28 days improves the likelihood of it's working.
Right.
And we've tended, if we have somebody wanting to be grade 2 or greater, we've tended to hold off on the Durva, because giving a Durva will kind of push them over the edge.
Oh, wow.
Yeah.
Quicker, you think?
Yeah. I mean, I just, if you want to start steroids, just start them on Durva. And if they're, but not every, there's, and I think what I'd say is these are the patients that come in, the med-onc is saying start steroids, and I'm saying they're fine, don't.
Right.
And they're saying start steroids so I can start Durva, which feels a little backwards. But
Okay.
Yeah.
Interesting. Thanks, sir.
Thanks. Absolutely. Go ahead.
Just a question.
Yeah, please.
Yeah, the radiation therapy leads to some alterations that would make FTG less reliable for
It can. I agree.
Is it the same? Is it different for Sabre, or is it just used because you don't have?
No, and in fact, I probably should have emphasized this. The routine use of metabolic imaging after radiotherapy, I think, is a mistake. And frankly, in all of cancer, and especially lung cancer, the routine use of metabolic imaging shouldn't be used. It does a great job of keeping biopsy services and businesses and paying off PET centers. It does nothing to improve the quality. So why do we talk about PET? Because if we have consistent radiographic findings that are concerning, then it's an appropriate next step before doing something invasive like a CT-guided biopsy. So I use it
Not for routine surveillance.
Not for routine surveillance. You probably should have emphasized that. Yeah.
Is there a time frame in a few months or a year after radiation therapy where you can rely on PET?
So the only time I would get a PET within a year of radiotherapy, and usually I never do, is if I'm continuing to see changes that have me worried and things are continuing to grow, or if I see some new area, let's say that they now have a new nodule, and I'm trying to characterize that nodule, then I'll get the PET primarily to look at the new nodule and its metabolic effects.
Thank you.
Yeah, absolutely.
Last question. This
Please,
is one of those
yeah.
graded, I have a patient things. But
Sure, yeah, go right ahead.
Actually, this is, so this patient had a pneumonectomy, this one surgery. And I forget exactly, I cannot remember where the node was positive, and it was felt that some additional radiation would be beneficial. One lung, okay. Here, I'm going to fast forward.
Yeah,
By
I
the
think
time I
I
saw
know
her.
where this is going.
Well, she's okay now, but I'm saying, but fast forward, guess what, she had post-operative AFib, so she was on Immunotherapy.
Yeah.
So I see her in about, I would say, 8 weeks after radiation therapy, cough progressed, and then she's obviously EFT changes, CT changes, and she's better. So anyway, the question is, this was in that setting, IMRT on Anu.
Yeah.
And I think it's an immunologic. I think it's a combination.
Oh, sure.
I think.
Well,
now the question is that in a bronchus negative, however, again, a difficult patient you really go after a transbronchial because she's only got one lung, so you got problems there.
Did you
Unless
just
you do.
empirically treat her? Yeah.
That's exactly.
So let me grab
by
my
the way,
bag and
she's-
I'll walk with
Yeah.
you. Yeah.
And she is better after her first, and there are a lot of other complicated things with her. So he's got some diastolic dysfunction. Anyway, some fluid retention of breath, but we don't want to see it should be pretty.
Yeah.
But anyway, what do you think? I mean,
Well, the one thing that
or
was
tell me about her physiology.
the only patient that I have